And thank you everyone for joining us for today's Suicide Prevention Cyber Seminar. Today's session is VA's video telehealth tablets, access to mental health care, suicide risk assessment, and suicidal behavior among rural and urban veterans. Our presenter today is Dr. Kritee Gujral. She's a health economist at the Health Economics Resource Center at the VA Palo Alto Healthcare System. Dr. Gujral, can I turn things over to you?
Thanks, Heidi. Hi, everyone. I'm Kritee Gujral, and I'm happy today to be talking to you guys about VA's video telehealth tablets, access to mental health care, suicide risk assessment, and suicidal behavior among rural and urban veterans. Today's agenda is that I'll first start by talking about the impact of VA's video telehealth tablets on mental health access, emergency department visits, suicide-related ED visits among rural veterans with mental health needs. And building upon this work, we've done some work to examine the impact of tablets on an expanded cohort, looking at urban veterans as well. And in this work, we examined potential disparities that could result from reliance on telehealth, specifically tablets. We then will talk about the impact of tablets on suicide-related VA hospitalizations and potential rural-urban differences. So this is ongoing and future work. And then we have a forthcoming paper that looks at the impact of tablets on patients diagnosed with substance use disorder. And as this is a group of patients that is at high risk for suicide, I'll present some findings from this work as well. And then finally, we'll discuss VA's suicide risk identification strategy, or the Risk ID program, which was modified in November of 2020, when VA implemented a universal screening requirement that may be particularly advantageous for rural veterans. So in today's talk, the work that I'll be describing or going over is work that spans across multiple different papers and studies. So I'll focus more on describing the findings across these papers. But folks that are interested in looking at more of the details of how the variables were constructed and the methods are welcome to look at these published studies or the emerging work. So with that, let's jump right in. So the first paper that I'll talk about is looking at the mental health service use, suicide behavior, and emergency department visits among rural US veterans who received video-enabled tablets during the COVID-19 pandemic. So to give you a bit of background, US suicide rates are at their highest since World War II, with over 500,000 suicides during 2001 to 2015. Suicide is increasingly affecting US residents in rural areas compared to urban areas. Veteran suicide rate has consistently been 50% higher than that of non-veterans, and veteran patients in rural areas compared to urban areas are more likely to die by suicide. And the COVID-19 pandemic has intensified risk factors for suicide. These risk factors disproportionately can affect rural residents, such as social isolation, intimate partner violence, and firearm access. And to describe a bit more of the access to mental health care and suicide prevention care, note that many veterans have mental health conditions that frequently go untreated due to access barriers and concerns about stigma. Reduced interaction with routine healthcare during the pandemic exacerbated these access problems and reduced opportunities to screen and treat residents for suicide risk, challenging suicide prevention efforts. So the pandemic's silver lining, this expansion of telehealth, may improve access to mental health care and help prevent suicides, especially for rural or underserved veterans who face greater access barriers and are at higher risk for suicide. However, there is a lack of evidence on the effectiveness of telehealth for suicide prevention. So that motivates our study to look at VA's video-enabled tablets, which were meant to facilitate um, access to care through telehealth. VA has been leading efforts to expand telehealth to address access issues among veterans residing in rural areas. In 2016, VA's Offices of Rural Health and Connected Care began distributing video-enabled tablets to veterans with access barriers to facilitate their participation in home-based telehealth. VA's tablet distribution efforts escalated during the COVID-19 pandemic, and as of November 2022, there were over 132,000 VA tablets in circulation, with 81% of these, with the total number of tablets being issued having been distributed during the pandemic. And approximately 31% of the tablets that were issued during the pandemic were issued to veterans living in rural areas. So this allows us to have a study that's focused specifically on rural veterans, where we can evaluate the impact of tablets among rural veterans. So given the lack of evidence about telehealth's effectiveness for suicide prevention, potential threats to mental health care access, and suicide prevention care during the COVID-19 pandemic, this VA's escalated tablet distribution during the pandemic presented an opportunity to pilot a scenario in which rural veterans face one less barrier to accessing home-based telehealth: smart device ownership. So focusing on rural veterans with indicated mental health needs, we evaluated the impact of VA's video-enabled tablets during the COVID-19 pandemic on the monthly frequency of mental health visits for psychotherapy and medication management. We also looked at comprehensive suicide risk evaluations that were administered during outpatient visits. We looked at emergency department visits, suicide-related ED visits, and suicide behavior and overdose reports within the VA. So to describe a little bit more about this intervention, the VA video-enabled tablets, veterans were eligible to receive VA's video-enabled tablets with data plans if they were deemed to potentially benefit from video-based visits, but lacked affordable or quality internet connection or a video-capable smart device. Veterans were prioritized for receiving tablets if they had an access barrier, such as transportation challenges or residing farther from the VA, or if they had complex clinical needs, such as a mental health condition. Providers initiated tablet consultation meetings for patients who they thought would qualify. And then if veterans were considered eligible after the consultation, they were ordered, tablets were ordered to be mailed for those veterans. Here I'm presenting the digital divide workflows. The digital divide consult was actually launched in the summer of 2020 and implemented in all sites by September of 2020. And this digital divide consult replaced the video telehealth tablet consult. And the workflow is sort of similar, where the care team would place a digital divide consult for a veteran. Then a social worker that receives the consult would complete an assessment for veteran needs. So once a social worker would assess whether or not the veteran needs the device, whether or not a veteran is interested in this device, and then eventually the social worker would place the device ordering consult, and then the VA device would get shipped to the veteran if they were considered to be eligible. Here the consult has been evolving since its first inception. So I've included additional details if folks want to look at details of these processes. For our study, we're looking at veterans living in rural areas who had at least one VA mental health visit in 2019. And we also examine a sub-cohort of rural veterans who the VA predicts to be at a higher risk of suicide, or they're classified as reach vet veterans based on an algorithm. So the study design that we use is an event study and difference analysis. We compare outcomes for patients who received tablets during the pandemic with patients who were never issued tablets, and we compare their outcomes 10 months before tablets were issued and 10 months after tablet shipment. So in these analyses, we've adjusted for patients' age, sex, race, ethnicity, homelessness, to the extent that we could measure homelessness, distance from VA, chronic conditions, risk of hospitalization, indicator for suicide risk, COVID-19 cases in the county where the patient lives, VA facility, month effects, and time invariant or fixed difference between recipients and non-recipients. And this event study methodology will allow for seeing outcome trends prior to tablets being issued. And if there are no differences in adjusted outcomes between tablet recipients and non-recipients in the pre-tablet period, but we see that there are abrupt differences between tablet recipients and non-recipients in the post-tablet period, then we consider that tablets are having an impact, or the differences that we see between tablet recipients and non-recipients in the post-tablet period are considered to be differences that we can then attribute to tablets. So there's a lot more discussion of these methods in the papers themselves, but I'll be walking through the event study methodology, and it'll become much clearer when I present the graphs and these patterns of how we understand tablet associations through these methods will become more clear when I show you the graphs and the results as well. Okay, so looking at the baseline frequency of outcomes for rural tablet recipients and non-recipients, we see here that the rural tablet recipients tended to have, were more likely at baseline to have had any psychotherapy visit. So 19% for rural tablet recipients versus 12% for rural non-recipients. And we see that across the video visit outcomes as well, we see that rural tablet recipients were more likely to engage with video at baseline than rural non-recipients. And with respect to ED visits and suicidal behavior as well, we see that rural tablet recipients compared to non-recipients were more likely to have an ED visit or suicide-related ED visit or suicide behavior or overdose report, which indicates that rural tablet recipients were more likely to be getting these tablets because they were using more video and they were assessed in the consultation to be more likely to use tablets, and that's why they were issued tablets. So there are these baseline differences between tablet recipients and non-recipients that we see, including when we look at covariates. We do see that tablet recipients tended to be slightly older. We saw that they had the number of chronic conditions, both physical and mental health, were slightly higher for rural tablet recipients than non-recipients. Rural tablet recipients were more likely to have indicators of substance use disorder or PTSD or depression than non-recipients. We also saw that they had a higher CAN score than non-recipients. They were more likely to have been indicated as a reach vet or high risk for suicide veteran than non-recipients. We saw that Hispanic veterans were slightly less likely to have gotten tablets compared to non-recipients. And we see that Black or African American veterans were more likely to receive tablets among other races. And here, that's where, the methodology that we're using allows for these baseline or level differences, and allows for us to rely on the fact that trends across these groups will be similar, and we're going to be able to adjust for the differences using the covariates and a fixed level difference between these groups. So what I mean by that is that you'll see that these are the results for the event studies, and we're showing these event study graphs, and you'll see in all of these graphs the red vertical line. That vertical line is marking the 2 months before tablet receipt, and on the left-hand side of that vertical line is the period prior to tablets being issued, and to the right-hand side of that vertical line is the period post tablets being issued. And so what we show here is that after adjusting for the several covariates and the fixed difference, the level difference between tablet recipients and non-recipients, we see that in the period prior to tablet receipts, there was virtually no differences in the effect, no differences in visits for tablet recipients versus non-recipients. But post tablets being issued, so right after, to the right side of the vertical line, we see a stark difference or a significant change in the pattern of effects or pattern of differences between tablet recipients and non-recipients. This is what allows us to say that the effects that we're observing are associated with tablet issuance, so it's the tablet timing that we're exploiting, and saying that we're not seeing differences prior to tablets, but immediately after tablets, after adjusting for these different covariates and patient characteristics, we see the tablets appear to increase visits quite a bit. So this figure A shows psychotherapy visits across all modalities. Figure B is showing video psychotherapy visits, so specifically visits via video. And then we're seeing video medication management visits, video comprehensive suicide risk evaluations. And what we see is that tablets appear to substantially increase video visits for these outcomes that we looked at. And for psychotherapy visits across all modalities, which is figure A, we're seeing that tablets appear to increase the total number of psychotherapy visits across both across in-person, phone, and video. So as for psychotherapy visits, we did examine total visits across all modalities for medication management and the comprehensive suicide risk evaluations, but we don't see that tablets increase the total number of medication management visits or the total number of comprehensive suicide risk evaluations, but we do see higher engagement via video for those outcomes and a total increase in psychotherapy visits. So focusing on the psychotherapy visits result here, we see the figures are showing the month by month effects or the differences between tablet recipients and non-recipients, now averaging over the full post period, comparing that full post period to the full pre-period, so taking the 10 months post and 10 months pre and comparing those periods, we find the tablets on average across this 10-month period were associated with a video visit increase of about 3.5 visits per year. And across all modalities, it ends up being 1.8 visits per year additional if you've got the tablets. And for the high-risk subcohort of rural veterans, graphs are not presented here, the tablet-associated increase in video visits was about 5.9 visits per year. And looking at psychotherapy visits across all modalities for this high-risk subcohort, we find the tablets were associated with 3.1 psychotherapy visits across all modalities per year. So for context, the baseline frequency for psychotherapy visits for tablet recipients in our full cohort was 5.5 visits per year. And in the high-risk subcohort of REACH veterans, it was 13.7 visits per year. So these tablet-associated increases of 1.8 visits per year for the full cohort and 3 visits per year for the high-risk subcohort translated to increases of 33% and 23% respectively. Now, looking at the emergency department visits and suicide-related emergency department visits and suicidal behavior and overdose reports, the graphs show us that in the pre-tablet period, which is to the left of the vertical line, we see that there's not much of a difference between tablet recipients and non-recipients, but right after tablets are issued to tablet recipients, we see that there's a reduction in the likelihood of ED visit for tablet recipients compared to non-recipients. And similarly, for suicide-related ED visit or a suicide behavior or overdose report, we see that compared to pre-tablets, we see a decline post-tablets. So averaging over the full period, we see that tablets were associated with a 20% reduction in emergency department visits compared to their pre-tablet baseline, and a 36% reduction in suicide-related ED visits compared to their pre-tablet baseline, and 22% reduction in reports of suicidal behavior compared to the pre-tablet baseline. So to summarize, video visits replaced phone or in-person visits in some cases, but constituted new or additional visits in other cases. We find that tablets were associated with increases of about 33% and 23% in the full cohort and in the high-risk subcohort of rural veterans compared to their baseline pre-tablet use. So this 33% and 23% increase in psychotherapy across all modalities. We see that clinical significance of these results is further emphasized by our complementary findings that the tablets were associated with decreases in the likelihood of ED visits, suicide-related ED visits, and decreases in suicidal behavior and overdose reports. So these results reinforced an earlier pre-pandemic finding that tablets improve continuity of mental health care and extended this prior work by focusing specifically on rural veterans and demonstrating that the effect of tablets extends to reductions in ED visits and suicidal behavior, including in the high-risk subcohort of rural veterans. So our next subsequent work builds upon this prior work. We were interested in looking at potential disparities in the impact of VA tablets on psychotherapy use. So we see this favorable impact for rural veterans. We wanted to look at what happens in a larger cohort where we can compare rural-urban differences and other differences across different sociodemographic groups. So what motivates this work is that there's research that has pointed to a digital divide, particularly among rural residents and racial and ethnic minorities who may lack access to computers, smart devices, or broadband or high-speed internet availability. Digitally isolated individuals often have a higher prevalence of chronic diseases and critical needs for healthcare. At the same time, telehealth can improve access to care for many individuals. Recent studies have suggested that telehealth may have mitigated the impact of the pandemic on healthcare use and health disparities. For example, women typically face greater access barriers due to disproportionate burden of caregiving and logistical difficulties in seeking care. However, women may be more inclined to use telehealth services than men, which can then mitigate the influence of existing access barriers if women have more access to telehealth. So given that technological advances, such as reliance on telehealth, could inadvertently increase health inequities, but could also ameliorate disparities, we built upon this prior work looking at rural veterans and examined the impact of tablet on differences in psychotherapy use between rural and urban patients, Black and white patients, and women and men. So in this study cohort, we include rural and urban veterans with a mental health visit in 2019, and we look at an expanded cohort of tablet recipients. So previously we were looking at rural veterans who received tablets from March 2020 to April of 2021. We're now looking at an expanded cohort of tablet recipients where veterans could have received tablets also from April to December onward. So you'll see that in our cohort, we've got 64,000 tablet recipients in total. We're comparing them to 1.4 million non-recipients, and the rural tablet recipients in this study are, there is about 18,000 of them, whereas in the previous study we had about 13,000. So in these 8 months, we had an increase in rural tablet recipients as tablets were being issued. In this study, we also include urban veterans. We have Black veterans, white veterans, women veterans, and men veterans, just kind of breaking down the cohort. We see that we're including about 21,000 Black tablet recipients. We're including about 9,000 women tablet recipients. So the study design that we use is very similar to what I've just presented in the work looking at rural veterans. We're using the event study and difference analyses, comparing tablet recipients and non-recipients before and after tablet receipt. So we're just going to be able to build off of that work and show you results sort of quickly, since we're leveraging these methods and a similar cohort, but a similar but expanded cohort. Okay, so the results that we see in this work is that receiving a VA video telehealth tablet was associated with increased psychotherapy use across all of these sociodemographic groups that we looked at. However, we did observe some modest variations in the extent of increase across these groups. So here I'm showing a graph of video psychotherapy visits, and it's stratified by rural and urban veterans. So we're showing rural veterans here in red and showing urban veterans here in blue. And the vertical line is marking the 2 months prior to tablet receipt, which is our baseline month. And to the left of that vertical line is the pre-tablet period, and to the right of that line is that post-tablet period. And in each case, we're comparing tablet recipients to non-recipients. So we're comparing rural tablet recipients to rural non-recipients, and we're comparing urban tablet recipients to urban non-recipients. And so what we see here, you can see in the graph, is that rural veterans post-tablets tend to have slightly fewer video visits, video psychotherapy visits, compared to urban veterans. So even though there's an increase for both rural tablet recipients and urban tablet recipients compared to non-recipients, we do see that the increase is slightly lower for rural veterans compared to urban veterans. So we see that this translates. So when we look at these video visits differences, we see that there isn't, when we look at psychotherapy visits across all modalities, however, we don't see that there is a statistically significant difference. And we see that rural veterans and urban veterans experience similar increases in psychotherapy visits across all modalities. So rural veterans, rural tablet recipients experience an increase in psychotherapy of about 27.4%, and urban veterans experience an increase of about 24.6%. Okay, so looking at women versus men tablet recipients, women veterans here are shown in the graph in the black line, and men veterans are shown with the green line. And what we see here, again, is that post-tablets, we see a marked increase in video psychotherapy visits for both groups. However, we see that women have a slightly higher increase in video psychotherapy visits post-tablets compared to men. And this averaging across the months, we see that women tablet recipients had about 1.2 more video visits per year, and 1 more visit across all modalities compared to men. So while women experienced a 30.5% increase in their psychotherapy visits across all modalities. Men experienced about a 24.4% increase in psychotherapy visit across all modalities. Looking at Black versus white tablet recipients, where Black veterans are marked with the orange line here and the white veterans are marked with the purple line here, you can see in the graph that both Black veterans and white veterans experience an increase in psychotherapy visits via video post tablets being issued. However, we see that that Black veterans have a slightly lower increase than white veterans, and this is looking at the average across the time period, Black versus white tablet recipients had 0.3 fewer video psychotherapy visits per year, which contributes to this 0.5 fewer visits per year across all modalities. So what we see is that for Black tablet recipients, the increase in psychotherapy visits post-tablet receipt was 20.8%, whereas for white tablet recipients, the increase in psychotherapy post-tablets was 28.1%. So in conclusion, what we're seeing here is that VA tablet receipt was associated with increased psychotherapy use across all sociodemographic groups, with modest variations in the extent of increase across these groups. These findings suggest that distributing telehealth-enabled devices help narrow the psychotherapy gap between rural and urban veterans and increased psychotherapy use among women, but device distribution alone may not reduce racial disparities affecting Black patients. There's a need to further explore why Black tablet recipients had a lower % increase in psychotherapy visits post-tablet receipt. Now, building on this work, we are working to look at the impact of VA tablets and telehealth initiatives broadly on suicide-related hospitalizations and suicide deaths. And given that we see potential disparities in the use of tablets, we're looking at psychotherapy, we're also going to look at the potential for disparities in the impact of VA tablets or VA telehealth on suicide outcomes or suicide-related hospitalizations, ED visits, or suicide deaths. So in this ongoing and future work, we're looking at the study cohort, the same study cohort where with veterans with at least one mental health visit in 2019. So this includes rural and urban veterans. We're comparing tablet recipients with non-recipients before and after tablet issuance in a similar study design. And the preliminary findings that we have that are presented in this graph to the left in the black line, where we're looking at any suicide-related VA inpatient visit, we see that post-tablets, which is to the right of the vertical dashed line, there we see a reduction compared to the pre-tablet period. And so we're seeing that tablets appear to be associated with a 33% reduction in the likelihood of a suicide-related VA hospitalization, which looks consistent with the 36% reduction in suicide-related ED visits that we've observed in our prior work looking at rural veterans. Now, when we try to stratify by virality, what we do see on this, so in this next graph, the second graph that is stratified by rural and urban, we see that the reduction is in suicide-related VA hospitalizations. We see that it's possible that that reduction is slightly greater for urban veterans compared to rural veterans. However, the rural-urban differences in this study were not statistically significant. It is possible that statistically insignificant differences here may be due to hospitalization being a sparse outcome and a relatively small sample size for rural veterans. So larger scale studies would really be helpful to examine the impact of tablets and other telehealth interventions on suicide deaths and potential disparities potential disparities of tablets or other telehealth on suicide prevention efforts. Okay, and then we took a look at a high-risk cohort where looking at patients diagnosed with substance use disorder. We took a look at impact of these tablets on substance use disorder care during the COVID-19 pandemic. To give you a little bit of background on this patient population, prevalence of substance use disorders, or SUD, and related adverse consequences such as overdoses and overdose-related deaths have been rising in the US for the past several decades. Patients with SUD typically also have high suicide risk, and utilization of effective treatment for SUD remains low, with lack of access to medication and psychotherapy for SUD being a major factor. Risks and access issues affecting patients with SUD were exacerbated during the pandemic. Telehealth has been underused and understudied among patients diagnosed with SUD. And as the country's single largest provider of telehealth services and substance use treatment, VA provides this unique opportunity to rigorously examine the impact of telehealth use among patients with SUD. Prior work has shown that veterans with SUD generally receive fewer video visits than those with other types of mental health disorders, but previous work examining veterans who received VA tablets found that tablet recipients with SUD preferred video visits to in-person visits. So in our work, our goal was to examine the impact of VA's video-enabled tablets on mental health services for patients diagnosed with SUD. We looked at a similar cohort as our prior work, where veterans veterans who had at least one mental health visit in 2019. So this included rural and urban veterans, but they also had a documented diagnosis of SUD. And we compared tablet recipients. So that was about 21,000 tablet recipients, and we compared them with about 267,000 non-recipients in a similar study design where we compared tablet recipients and non-recipients before and after tablet issuance. And so if I can draw your attention to the graphs here, I'm showing here the video visits for group therapy, video individual outpatient visits, and video SUD psychotherapy visits. And so what we see is that to the right of the vertical line, which marks the post-tablet issuance period, we see a marked increase in video visits for group therapy, individual outpatient visits, and psychotherapy for this cohort that received tablets compared to non-recipients. So we see that averaging across these months, we see that tablets were associated with an increase in video visits for SUD specialty group therapy, about 2.1 visits per year, and we see that tablets were associated with increased video visits for SUD specialty individual visits, about 1 visit per year, and SUD psychotherapy visits, about 3.5 visits per year. So these video visit increases did translate to modest visit increases across all modalities, so totaling up and looking at visits that occurred either via in-person or via phone or video. We see that post-tablets, there was a 10% increase in SUD specialty group therapy visits, a 4% increase in SUD specialty individual treatment visits, and the highest increase that we saw was an 18% increase in SUD specific psychotherapy. And then when we looked at findings in specific subgroups, we found that the findings were similar when we looked at patients with patients who were ever homeless during the study, patients who were Black, patients living in rural areas, or patients living farther from VA facilities. So what we see here is that tablets are a valuable tool in improving access to care for patients with SUD, which is a which is a high-risk group for suicide and high-risk group overall, and particularly when there were barriers to accessing in-person care. But it is important that given we do not fully understand the ramifications of the rapid switch to telehealth during the pandemic for patients with SUD, it's critical that we continue to track the substitution of in-person visits with psychotherapy visits and track how this the substitution affects health outcomes among this population of patients. So slightly switching gears here from tablets, I want to talk a little bit about our newest paper and the newest findings about VA's looking at VA's universal screening and evaluation program, because it has potential benefits for rural veterans and has implications for veterans with access barriers. I'll talk a little bit about this implementation program and then summarize across these different papers. So VA has taken several steps to ensure that veterans, including those living in rural or underserved areas, have access to adequate mental health care so that their prevention efforts, VA's prevention efforts can come to fruition. Early and accurate detection of suicide risk among all veterans presenting for care is a critical strategy towards reducing overall veteran suicides. And so with that, in November 2020, VA implemented a universal screening requirement, which to our best knowledge represents the largest suicide screening intervention in the US. VA has previously led the way on suicide prevention efforts and that are now considered best practices. So in light of recent nationwide efforts to prevent suicides via universal suicide screening, we conducted a descriptive evaluation of VA's large-scale and nationwide implementation of universal screening to provide early insights into this program. So to give you a little bit of background, VA expanded its suicide risk identification program, Risk ID. So the original Risk ID program from 2018 included 3 steps where there was a primary screen, the item 9 of the patient health questionnaire. And the primary screen ended up being positive for a veteran. They were supposed to be administered a secondary screen, the Columbia Suicide Severity Rating Scale, or the CSSRS screener. And then if the secondary screen ended up being positive for a veteran, they were supposed to be administered a comprehensive suicide risk evaluation. So this is a questionnaire with more in-depth questions about suicidal ideations or history of attempts. So in this original Risk ID in 2018, individuals who screened positive at one step moved on to the next level of screening or evaluation. And implementation of this Risk ID in ambulatory care settings was initially focused on veterans due for annual screens for depression and or PTSD. Risk ID was then modified in November 2020 with an expected implementation start date of December 2020 and a definitive start date of January 2021. And the risk identification strategy then reduced from these 3 steps to 2 steps, where the I-9 was now removed and the CSSRS became the primary screener, followed by the CSRE. So if veterans were screened, if veterans had a positive CSSRS, they were to be given a follow-up comprehensive suicide risk evaluation, or CSRE, where sometimes CSREs may also be administered as the first step without the CSSRS screener if providers thought that that's how they should screen the veteran. They use the CSRE at times. Okay, so at the same time that the I-9 was removed and the CSSRS became the primary screener, the VA also implemented a new policy requiring that all veterans receiving VA care were screened at least annually. So this is the universal screening requirement. And this universal screening was designed to increase detection of suicide risk among veterans receiving care across a wide range of settings. So if veterans went to primary care, specialty medicine, or for an audiology appointment, or for a mental health appointment, that if they were due at any of those visits for their annual screen, that they would then get screened at those settings. The objective of our work was to examine the associations between this implementation of universal suicide screening and veterans' likelihood of screens, follow-up evaluations, and suicidal behavior. The study cohort that we looked at was veterans who had a VA mental health, at least one VA mental health care visit in 2019. So this included rural and urban veterans, so leveraging the data set and the cohort that we had been working with previously. We took a look at the pre-post outcomes. So that's before and after the start of the universal screening policy in November 2020. So here I'm showing the unadjusted results. If I can draw your attention to the graphs here for a second, we see that the red vertical line is when VA's universal CSSRS or the universal screening or the Columbia screening, Columbia screener becoming the primary screen, removing the I-9, and the universal screening being implemented. That intervention occurred where we have that red line. So this is the modified risk ID program was implemented in November 2020 with the effective, definitive and effective start date being January 2021. So just looking at these unadjusted results, we see that the likelihood of screening via either CSSRS or I-9 increases immediately post implementation. And then when we look at the likelihood of screening via CSSRS in the second graph, we see that that's the increase in likelihood of screening via CSSRS or the Columbia screener is greater, and that's what's driving the increase across either suicide screen. So that's because we're in a transition period in this analysis where we're looking at the I-9 was the primary screener, and then the CSSRS became the primary screener. So we want to look at what's happening with suicide screens overall. And if you're looking at this particular time period, it would be good to look at both types of screeners. So that's what we do in this first graph. So what we see here is that a large portion of the population who had not received a CSSRS screen in the previous year became due for an annual screen post-implementation, and this resulted in the volume of screens early into the post-implementation period increasing, with the volume slightly leveling out over time. So what we see here is that 12 months post-universal screen implementation, you see that 1.3 million veterans in our cohort, so like 80% of the study cohort, were screened or evaluated for suicide risk. Now, 91% of the subcohort who had at least one mental health visit in the 12 months post-universal screening period was screened or evaluated. So if they had at least, so to the extent that we could see if veterans had a mental health visit, we saw that 91% of those that had a mental health visit in those 12 months period post-implementation got the screen that they were supposed to get. And then what we found was that at least 20% of the study cohort that was screened outside of mental health care settings, which highlights the benefits of a universalized approach, that you could have patients that are at risk, that have prior mental health needs, but they could get screened for suicide even outside of mental health care settings. Now, looking at adjusted results, we see a similar trend where, so by adjustment, I just mean that adjusting for patients' age, sex, ethnicity, race, their clinical characteristics, what we see is that an additional 30,000 veterans per month were screened via either CSSRS or I-9 post-universal screening implementation, and this is driven by the increase in screens occurring via CSSRS, which is the new screener, the new primary screener, and replaces the I-9 Okay, so then looking at these adjusted results stratified by rurality, what we see is that the red line marks rural veterans and the blue line marks urban veterans. What we see here is that compared to their urban counterparts, there were about 7,000 additional rural veterans per month that were screened via the CSSRS post-universal screening implementation. And then when we look at CSREs, so the comprehensive suicide risk evaluations, if there was a positive CSSRS, we see that post-implementation, there's a rise in the CSREs being administered upon positive Columbia screens. And in terms of suicide behavior and overdose reports, we see that there's a general declining trend post implementation of this universal suicide screen. However, in terms of looking at the difference between rural veterans and urban veterans, we don't find a statistically significant difference, but some of that might be because we have smaller sample sizes and these outcomes being stratified by rurality should be tracked further in a larger study that can definitively say that there aren't any differences across rural and urban veterans, but here we don't see any clear differences. Okay, so what we find here is that with this early evidence, we see that a universal approach can supplement suicide prevention care for this population, leveraging opportunities to screen for suicide risk in all patient interactions within the healthcare system, especially for rural veterans who typically have lower access to care. So just summarizing across the different studies that we've seen here today, what we see is that veterans consistently have been at higher risk for suicide than non-veterans. Veterans in rural versus urban areas are more likely to die by suicide. Many veterans have mental health conditions that frequently go untreated due to access barriers and concerns about stigma. Risk factors for suicide increased during the pandemic and at the same time as access to care was interrupted. So while telehealth can improve access to mental health care, its effectiveness for suicide prevention has not yet been established. So looking at veterans living in rural areas, we found that VA's video-enabled tablets that were issued during the COVID-19 pandemic were associated with increases in video visits for mental health care and suicide risk evaluations. We saw that there were clinically significant increases in psychotherapy visits across all modalities in this cohort. We saw that there was a reduction in emergency department visits, reduction in suicide-related emergency department visits, and a reduction in suicide behavior and overdose reports. We saw the effects persisted even in the sub-cohort of rural veterans that were considered at higher risk for suicide. Building on this work, we looked at an expanded cohort, which included both rural and urban veterans, and we found that the favorable effects of tablets on psychotherapy visits persisted. As telehealth can inadvertently increase health inequities, we examined sociodemographic differences in the impact of VA-issued tablets. And what we found was that tablets helped narrow the psychotherapy gap between rural and urban veterans and increase psychotherapy use among women. But device distribution alone may not reduce racial disparities affecting Black patients. And there's a need to understand why Black recipients had a lower percentage increase in psychotherapy post-tablets. Our ongoing and future work examines whether tablets can reduce suicide-related hospitalizations and suicide deaths, and if tablets or telehealth can do so equitably. And preliminary results suggest that tablets are associated with a 33% reduction in suicide-related VA hospitalizations. However, there's a need for larger scale studies to examine differences in the effects of tablets across sociodemographic subgroups. Because effects of tablets may also differ across mental health conditions, we took a look at patients diagnosed with substance use disorder who are typically also at high risk for suicide. We found that tablets facilitated continuity of care through video subspecialty services as well as subspecific psychotherapy. And we saw that findings persisted when we examined rural patients or patients who were ever homeless during our study period, or if patients were Black, or patients who lived farther from VA facilities. So these VA-issued tablets remove an important access barrier for veterans, the barrier of owning a smart device with internet connectivity and a data plan. We found that these tablets they improved engagement in video services for veterans with access barriers. Tablet-generated increase in video visits often translated to increase in mental health service use across all modalities, but in some cases, video visits also replaced in-person or phone visits. So it's critical to track how substitution of in-person visits and with these video visits influences health outcomes, especially for patients at risk for suicide or patients diagnosed with SUD, as effectiveness of telehealth for SUD and suicide prevention has not yet been established. And then tablets are just one of VA's many telehealth initiatives, and it is an initiative that removes an important barrier of device ownership. Reliance on telehealth more broadly could have adverse effects for patients who do not have access to smart devices or high quality internet, and additional large-scale studies are needed to evaluate the effectiveness of VA's telehealth programs for suicide prevention and for examining potential disparities. Finally, while there has been pandemic-driven expansion in VA telehealth, VA has simultaneously also modified and expanded its risk ID program, including implementation of this universal screen requirement. Given that veterans in rural areas may face greater barriers to accessing care, this universal approach to screening may be especially advantageous for reaching and screening rural patients, and then connecting rural patients with appropriate follow-up care. As the universal screening approach relies on VA visits, though, it will be important to ensure continued access to VA and track patients receiving VA paid care in the community or outside VA. Telehealth may offer an important strategy for improving reliance on VA care and improving the ability to detect suicide risk among all patients. It is critical to continue to track VA's telehealth initiatives and VA's universal screening program to inform national suicide prevention strategies. With that, I'll stop here. I know we covered quite a few studies, so I'm happy to take any questions that folks might have.
Great, thank you. We do have a few pending questions here. We're almost out of time, but we'll get through what we can here. First question, did possessing a tablet allow the recipients to access the internet, Google, interact with others, or were they only used for mental health consults and assessments?
That's a great question. Thank you, Heidi. So we discussed this in our first paper, in the limitations that we're not able to observe all the mechanisms through which tablets are having an impact in helping reduce suicidal behavior. But there are, so to answer that question, there are tablets are allowing veterans to be able to access Google. They're going to allow patients to connect with family and friends. So there's all these other mechanisms, not just mental health care alone, that could be the reason or could be factors that are driving the ultimate favorable impact that we see of tablets.
Great, thank you. The next question here, could the lower percentage increase in visits with Black recipients be an artifact of Black patients having a higher than average percentage receipt of tablets? Maybe since more of them are receiving tablets, it folds in a larger fraction population who wouldn't benefit but got a tablet anyway, while other groups, those who wouldn't benefit, were simply filtered out of the intervention earlier and never got tablets.
Yeah, so there are several there. We have not explored this question just yet, so I can't answer definitively, but the mechanism that's pointed out here, that Black veterans were more likely to get tablets. So is it possible that some of them don't need them but are getting them? It's possible, but comparing all of the need-based measures, we're seeing a difference to the extent that we can observe need using the existing data. So looking at mental health chronic conditions, we're still seeing a disparity. So it's something that we need to explore further. If there are unobserved variables that are different between Black tablet recipients and white tablet recipients that somehow indicate that Black recipients that are slightly more likely to receive it may not need those tablets. There's no evidence to support that, but this is something that is possible and we will be looking into in the near future.
Great, thank you. The next question here, how was rurality determined?
We define rurality based on the commuting area codes. So if this was based on patients' residence and seeing if patients' residence fell under the commuting area, what was the commuting area code of the patient residence. And I think it was greater than 1.1 was classified as rural.
Thank you. And it looks like this is our last question. Many PACT teams were prevented from having face-to-face visits during COVID. Was there a similar restriction for mental health visits that may have confounded the relative engagement of the veterans of all backgrounds?
So I guess I'm wondering if that question is discussing specific clinical areas that were prevented from having face-to-face visits, or is it about certain geographic areas that were limited?
We'll see if we get a clarifying statement in here. We did get a comment in that they can do other VA appointments on their tablet, not just mental health.
Yes, that's correct.
Okay, and back to the PACT teams question, mainly service line, not geography.
Okay, yeah, so we looked at, we're not aware that there was service lines that were restricted from using tablets, or sorry, that were restricted from using video visits for the service lines that we examined. We think that there was no such restriction, but there could be other service lines that we have not looked at that had restrictions within mental health care. We've worked with the program evaluation resource center at the VA Palo Alto to identify the outcome measures that we would expect that video visits were allowed for, but we're not sure if they were actually occurring. So those are the visits that we looked at.
Great, thank you. And that is all of our questions. Dr. Gujral, do you have any closing remarks you'd like to make as we finish this up here?
No, this was, thank you for all the questions and thank you for the opportunity to present our work. So like I said, we've got the papers that are published if people want to refer to those for more details, or please feel free to email me. I know we're over time and we covered a lot here, so feel free to email me if there are any other additional questions.
Great, thank you so much for taking the time to prepare and present today. We really do appreciate it. For the audience, I'm going to close the meeting out here. When I do, you will be prompted with a feedback form. We would appreciate if you took a few moments to fill that out. Thank you everyone for joining us today, and we look forward to seeing you at a future HSR&D Cyber Seminar. Have a great afternoon, everyone. Thank you.